We are live.
A very good evening, everyone. Welcome to iFocus Online, Lecture 264, Uvea Module number 5. Today we have with us Dr. Gazal Patnaik from Sankara Nethralaya, Calcutta, talking to us on laboratory tests and systemic imaging in uveitis. I invite Kalpana ma'am to please introduce her to our audience.
Thank you, Dr. Shefali. It's my pleasure to introduce Dr. Gazal Patnaik. Gazal has done her MBBS from Odisha and also post-graduation from there. And she has done her fellowship in Uvea and medical retina in Sankara Nethralaya, Chennai. A young and a very enthusiastic uveitis consultant at Sankara Nethralaya. May I please invite her to give her talk today on laboratory and systemic investigations in uveitis. Thank you, Gazal, over to you.
And before starting the session, I actually want to thank all the moderators and the panelists who are there. Because of you all, the discussion becomes extremely important. And Dr. Mamta ma'am, Dr. Parthopratim sir, Dr. Abhilasha, thanks a lot for being there. And of course, Dr. Kolkotta ma'am and Dr. Biswas sir and Amod Gupta sir, who will be joining soon. The discussions are actually important because of your presence. So thank you so much for sparing your time for us. Over to you, Dr. Gazal.
Thank you so much. Thank you, Kalpana ma'am, for such a nice and elaborative introduction. So, without wasting much time, I would like to start my talk on lab investigation, systemic imaging, and in uveitis. Before I start that, I would like to share one feeling that when I was a postgraduate and a fellow, and I had this topic, I was literally bored and like, why do even we want to know details about all these lab investigations? But as a uveitis specialist, we are not just an ophthalmologist, we are a kind of mixture of all, and we are a bit of lab technicians as well. I would try to keep this talk less boring and more relevant as much as possible. So we'll start with infectious and then go to non-infectious categories. We will be dealing with each uveitic entity separately. So the most common being tuberculosis. Let's start with that. So usually the primary lab investigation, if we suspect tuberculosis, is tuberculin skin test, or the commonly called the Montus test. It was first described by Koch in 1890, later on modified to intradermal use by Charles Montus in 1912. It is basically a delayed type 4 hypersensitivity reaction to purified protein derivative. This PPD is prepared by precipitation of proteins from heat-killed cultures of mycobacterial tuberculosis. So a standard dose of 5 tuberculin units in 0.1 ml is injected intradermally on the volar surface of the forearm, and the result is interpreted after 48 to 72 hours in terms of erythema and induration. Diameter of the induration is measured perpendicular to the long axis in millimeters. It is the sensitized T cells that are recruited to the site of injection, and there they release the lymphokines that leads to erythema and induration. Usually, roughly an induration of 10 mm or more is considered positive. 5 to 9 is doubtful, less than 5 is negative. But we have to pay attention in few other special conditions for a proper interpretation. Like even 5 to 10 mm induration is taken as positive if it's an immunocompromised individual. So we need to be careful for false positive and false negative. False positive is possible if it is an atypical mycobacterial infection or the individual is BCG vaccinated. False negative could be seen in recent TB infections or in immunocompromised state. So a clinical correlation is a must. For false negative suspects, retesting should be done at around 10 weeks after the TB exposure has ended or when the child is more than 6 months of age. The second most common test we do for tuberculosis is interferon gamma release assay. It measures the interferon gamma that is released after a stimulation of T lymphocytes with mycobacterial antigens like ESAD6, CFP10, and TB77. So basically, these are taken into consideration because they are absent in BCG strains and in non-tuberculous mycobacteria. There are two commercially available IGRAs, that is quantiferin gold TB in tube, and it's a whole blood enzyme, whereas other one is T-spot TB. It is T cell based enzyme linked immunospot assay. The difference means the first uses whole blood, second uses T cell based enzymes, and the first one uses all the three peptides, whereas the second one uses ISAT6 and CFP10 antigens. So from this we know that not only the IGRAs indicates infections, it also helps to quantify the severity. So higher the mycobacterial load, higher is the T cell sensitization that produces higher levels of interferon gamma. So it is more specific test for tuberculosis that indicates infection or previous exposure. It is not influenced by prior BCG vaccination or exposure to atypical mycobacteria. It requires single patient visit, and it gives a quantitative measurement of interferon gamma release. However, the main disadvantage is the higher cost, the need of a trained technicians and specialized instruments, so logistic becomes a major issue. Also, it has a reduced sensitivity in immunocompromised patients and children. The role of this TST and IGRAs has been evaluated, and IGRAs, they can be used for diagnosing latent TB in low endemic areas where the specificity is around 92 to 97%. But why is it not preferred in India? Because in TB endemic countries, does not add much value to the interpretation, because it cannot distinguish latent from the active disease. And in endemic countries, the focus of prevention control is to treat and identify and treat the active cases. Recently, quantiferin gold plus has been introduced. The basic difference is that it contains two antigen tubes, TB1 and TB2. TB1 contains two peptides and is designed to stimulate CD4 response, whereas TB2, it contains all the three antigens, peptides, and that stimulates both CD4 and CD8 antigens, T cells. This is just a summary of everything. Coming to the diagnostic microbiology, the presence of acid-fast bacilli indicates tuberculosis. It's an easy and quick one. However, culture confirms the diagnosis, and culture examination should be completed regardless of the acid-fast bacilli result. So although it is highly positive, it is not possible because of the slow growth of the bacilli. The sensitivity is further reduced when we use biological fluids like aqueous and vitreous, especially when these liquids are inoculated on the solid media. So for that, an automated liquid culture system, that is mycobacteria growth indicator tube, have decreased the incubation time period. Utility in TB endemic is very high, but again, the cost limits its use. It is used for diagnosis of tuberculosis as well as drug susceptibility under Anti-CCP program. So it is not only crucial to diagnose an MTB, but it is also crucial to identify drug resistance as early as possible. Drug susceptibility pattern should be repeated for patients who do not respond adequately to treatment or have a positive culture despite 3 months of therapy. Molecular tools such as nucleic acid amplification or the NAT, PCR, Gene Expert, and RIF has emerged as a promising tool. They have added advantage to detect drug resistance. Ocular fluid samples is usually low, and that affects the amount of DNA load and hence the sensitivity and specificity. This expert MTB and RIF is an automated cartridge-based nucleic amplification assay that can detect MTB as well as rifampicin resistance. High sensitivities and specificities from vitreous samples has also been documented. Coming to the systemic imaging, chest X-rays are the usual go-to at the first visit. Ultrasound, abdomen, pelvis, and HRCT chest, MRI, brain and orbit if you suspect CNS transmission. I would skip this due to time constraints. Coming to the second most common, that is the sarcoidosis. the first international workshop on ocular sarcoidosis proposed 7 clinical signs and 5 lab parameters to diagnose an ocular sarcoidosis. This has high predictive value in case of ocular sarcoidosis. Negative tuberculin test is an important biomarker, especially in countries where BCG vaccination is performed routinely. Serum angiotensin converting enzyme and serum lysozyme, they measure the same parameter, that is microphage load secreted by the sarcoid granuloma. However, serum ACE can be raised in various other pathological conditions and even in children. Coming to the radiology part, bilateral hilar lymphadenopathy is the most common radiological finding in systemic sarcoidosis. However, HRCT is now considered the gold standard and it's undoubtedly superior to the conventional chest radiograph, especially in cases of atypical presentation and delineating patterns. So the American Thoracic Society and other experts have recommended that the CT scan should be used, especially in such conditions where there is atypical clinical as well as radiological finding. If there is a pulmonary complication on chest X-ray like bronchiectasis, aspergillosis, or if you have a high clinical suspicion of the disease. Then we always have this debate of TB versus sarcoidosis. Systemic imaging can help in few conditions. Broadly, hilar lymphadenopathy is seen in both the diseases. However, bilateral hilar nodules and fissural nodules are seen in sarcoidosis. And if necrosis is seen, that is tuberculosis. Coming to gallium scintigraphy, this is age-old and historical purpose for theoretical purposes. It uses gallium-67, which is concentrated at the site of inflammation, and it can be seen in other diseases like Sjogren's. This has a low specificity for sarcoidosis, but it is highly sensitive. It has to be kept in mind that a confirmed diagnosis of sarcoidosis can be made only by biopsy that demonstrate a classic non-casating granuloma. Bronchial or transbronchial biopsies and bronchoalveolar lavage are usually recommended. Video-assisted thoracoscopy lung biopsy is confirmatory in more than 90%. Other possible sites are like skin, lesions at any site, skin, lip, or superficial lymph nodes, nodes, any visible lesions actually. Even some has proposed blind biopsy of conjunctiva, that is biopsy in the absence of any visible lesion of conjunctiva. CD4-CD8 ratio in the bronchoalveolar lavage fluid also has been used for diagnosis of sarcoidosis. So a ratio of more than 3.5 has been found to have a specificity of 24%. It has also been evaluated from the vitreous sample as well. Another historical importance test is the Wens test. Antigen prepared from the spleens of the patients with proven sarcoidosis are injected intradermally to see whether there is any hypersensitivity reaction in suspected sarcoidosis. Coming to the great masquerade syphilis, direct method includes detection of Treponema pallidum by dark field microscopy, direct fluorescent antibody stains, and PCR and immunohistochemistry. The sensitivity and specificity of this dark field microscopy is 90 to 100%, but it is seldom applicable and it is not commonly available, and it is very technologically challenging. Hence, indirect methods come into play, that is serological test, which remains the standard detection method, and they are broadly categorized into non-treponemal and treponemal. The non-treponemal term refers to antigens cardiolipin and lecithin, which are extracts of normal mammalian tissues. So the test detects both IgG and IgM antiphospholipid antibodies against these antigens formed by the host in response to the lipidal material released from the damaged host cells, as well as to the lipids on the surface of Treponema pallidum. Seroconversion usually occurs from 21 days till 6 weeks of the infection. And the two most commonly used tests are VDRL, that is Venereal Disease Research Lab, and the RPR, Rapid Plasma Reagent, as well known to all. But they have their limitations, such as reduced sensitivity in primary, late latent, and tertiary syphilis. False positive results could be possible again due to cross-reactivity, and these are seen in bacterial, viral, parasitic, and number of infections. Also, systemic connective tissue disorders like SLE or advanced agent, it not only mimics ocular variant this thing, but also mimics other microbes. False negative results are seen in concomitant infection with HIV. The tests are interpreted as reactive, weakly reactive, and non-reactive. A fourfold increase in antibody titer indicates infection, reinfection, or treatment failure. A fourfold reduction, however, suggests a response to the treatment. So these tests are recommended to monitor the course of disease during and after the treatment. The patients has to be evaluated after 3, 6, and 12 months of the treatment to assess the response and even to detect any reinfection. If the non-treponemal test shows persistent reactivity at 6 months despite treatment, it indicates seroresistance or serofast state. Then coming to the treponemal test, treponema pallidum hemagglutination assay or the TPHA, it is a microhemagglutination assay for IgG and IgM antibodies where the sensitized sheep RBCs are coated with treponema pallidum. This is the Nicole strain. The test is reported as reactive if agglutination occurs in a dilution of 1:80 or more. It is usually seen at 4th to 5th week of infection. Other tests are fluorescent treponemal antibody absorption. It is an indirect immunofluorescent antibody where the reactivity shows by 3rd week of infection. Others are like chemoluminescence immunoassay, enzyme immunoassay, and rapid test. So this treponemal tests, they remain reactive for years with or without treatment. They are mainly used to confirm the reactivity in non-treponemal test. Also, they are not useful to monitor the response to treatment or relapse or reinfection, and they correlate very poorly with the disease activity. These are also very expensive and difficult to perform. 3 testing algorithms are actually recommended nowadays that includes traditional algorithm, reverse algorithm, and European. I won't go into details. We'll stick to the labs. In case of any doubt, can repeat this test after 2 to 3 weeks to confirm the diagnosis. So CDC has recommended a lumbar puncture for CSF analysis in all patients of ocular syphilis to detect neurosyphilis. The diagnosis is based upon a positive VDRL, elevated total protein, and CSF pleocytosis. The CSF VDRL has a very high specificity, but sensitivity is only 50%. Consequently, a negative CSF does not rule out neurosyphilis. Besides the serological test, intraocular fluid analysis has also been evaluated in cases of diagnostic dilemma. And Shipra et al. Have concluded that the vitreous treponemal antibodies can act as a supplementary test to serology for confirmation of syphilitic choroiditis. Coming to the other tests like lepromin test for leprosy, incidence of leprosy is coming down, so this test is rarely used. It is used to determine whether the patient has leprosy and if so, what is the type. So the inactivated leprosy bacteria is injected just under the skin on the forearm, and after 28 days, the reaction is seen. People who do not have a leprosy will have little or no skin reaction, whereas people with lepromatous leprosy who are loaded with leprosy bacilli, they are allergic to the antigen and hence have no skin reaction to the antigen. Positive skin reaction is seen in patients with tuberculoid or borderline tuberculoid leprosy. So the diagnosis remains clinical. The ocular signs are often subtle. The characteristic skin lesion with definite sensory loss are cardinal signs of leprosy. The gold standard for confirmation remains identification of acid-fast bacilli in the skin smear with Phyte Farraco modification of carbol-fuchsin stain. Many serological tests have been developed to detect the circulating antibodies against Mycobacterium leprae. That includes phenolic glycolipid leprosy proteins. So the PCR has a high sensitivity in patients with multibacillary disease and not in paucibacillary diseases. Leptospirosis is a viral waterborne spirochete. Dark field microscopy can visualize the organism from body fluids. Microagglutination test is the gold standard where we see a live motile bacteria being added to the titrated amounts of the patient's serum. So if the serum has antibody, then agglutination happens, and that can be seen through this dark field microscopy. Sensitivity is very low, however, it is very specific. The next test is the microagglutination test, which is a very complex test to control, perform, and interpret. Other drawbacks are like continuous risk of contamination. IgM ELISA is more readily available and should be considered preliminary, and further confirmation by MAT is recommended. Other serological tests available are macroscopic agglutination, indirect hemagglutination, leptodistic, and microcapsule agglutination lateral flow assay. In addition to the above serological, PCR and immunohistochemistry also helps in the diagnosis. A little bit on the ELISA. It is a plate-based assay technique to detect and quantify viruses, proteins, antibodies, and hormones. We can use various antigen-antibody combination actually. The procedure includes either an enzyme-labeled antigen or antibody. From the final enzymatic activity, the result can be interpreted. The second one is the Western blot. It is a very sensitive assay for identification of proteins. It is based on chromatography principle. In this principle, the proteins are first separated into polyacrylamide gel according to their molecular weight and then transferred to the nitrocellulose membrane. Then these proteins are identified using an initial specific primary antibody followed by secondary enzyme labeled antibody and substrate. Other rare diseases like Lyme's, again here the ELISA is most often used test. It detects the antibodies to Borrelia burgdorferi, but because it can provide false positive test also, it is not the sole basis of diagnosis. The test might not be positive during the early stages of the Lyme disease as well. Then we do a Western blot test. If the ELISA is positive, we do Western blot to detect the antibody and confirm the diagnosis. Coming to rickettsia, rickettsial infections are caused by obligate intracellular gram-negative bacteria. It is usually transmitted to humans by bite of ticks and mites. Diagnosis is based on culture, nucleic acid amplification, serological tests like Will-Felix test, ELISA, rapid diagnostic test, and immunofluorescence assay. So the Will-Felix test is a hemagglutination test which is widely used for screening. ELISA is less expensive and it is easy to perform. Immunofluorescence remains the gold standard, but it needs skill, precision, and is not routinely available. So the serological diagnosis is the first, but it has various disadvantages also due to poor sensitivity during the acute infection, where antibodies are not detectable within the 10 to 40 days. The next infection we are dealing with is the dengue. Dengue is a mosquito-borne infection. Various serotypes are available. We need to focus on the time period. That is, the primary infection results in increase in the IgM antibody by 3 to 5 days post-infection, and that persists for around 1 to 2 months of the infection. Secondary infection, they show a rapid increase in the serum IgG as early as 3 days of the illness and late appearance of IgM. Hence, a ratio of IgG and IgM during the acute phase can help identify whether it's a primary or a secondary infection. The standard serological test for dengue is ELISA. The IgM antibody capture ELISA is used for qualitative detection. The only limitation is that it lacks specificity and shows cross-reactivity with other flaviviruses. However, presence of a high titer or a 4-fold increase in the serum confirms the dengue infection. Plague reduction neutralization test can detect specific neutralizing antibodies. It measures titers of neutralizing antibodies and usually used to distinguish dengue from other viruses. However, it is very expensive and it requires special labs. Chikungunya, it is caused by chikungunya virus. This infection has a clinical similarity with other arboviruses. The common lab test includes serological test and viral RNA detection by reverse transcriptase PCR. During the first week of infection, the RT-PCR should be ordered to detect the viremia. And why is it so? Because the IgM, as shown in the chart, it the levels rise by the level rise by day 7. So at this stage, IgM antibody assay would be helpful. After 14 to 21 days, both the IgM and IgG test would be positive. IgM levels, they wane over next few months, whereas IgG remains for years. A 4-fold increase again in the antibody during acute or convalescent stage are usually diagnostic. Various serological tests available for this are IgM, ELISA, immunofluorescent, hemagglutination, plaque reduction neutralization test, as has been discussed earlier. These are very specific and gold standard. Coming to toxoplasma, the diagnosis is mainly clinical, but serological assay helps in confirming the presence of toxoplasma. However, to note here is that the seroprevalence differs with geographical areas, and screening test includes ELISA and chemiluminescence immunoassay. But these tests are very simple to perform, low cost, and require small amount of serum. Other tests are like immunofluorescent antibody test, immunosorbent agglutination assay, and ability test. These are very complex and expensive to perform. Active infections, they stimulate the innate as well as acquired immunity. This IgM appears at the end of first week of infection, and they begin to fall in 4 to 8 weeks. IgG appear after 2 weeks, and they peak by 3 months of infection, and they persist. Absence of both these antibodies, they rule out the presence of any toxoplasmic infection. Positive IgG and negative IgM denotes previous infection. High serum IgG are not reliable indicators of either recent or reactivation. However, if there is a 3 to 4 times higher than the normal, then it should be repeated 3 weeks. And if it shows increasing titers, it may be considered as an active infection. In congenital toxoplasmosis, presence of IgM and or IgA confirms acute infection. Only IgG antibodies in neonate rules out toxoplasma because maternal antibodies also cross the placenta. In immunosuppressed patients, positive serology suggests infection. However, negative tests do not exclude concurrent infections. Besides the serum, levels of antibodies can also be tested in aqueous humor. Goldman-Whitmer is a very useful test. If it is greater than 4, then it indicates a recent infection. Sabin-Feldman dye test, though it remains a gold standard, complement-mediated neutralization test that requires live tachyzoids. These antibodies, they bind to the live tachyzoids and kill the complement-mediated lysis. So if there is a 50% killing of the tachyzoids, that is considered as a positive result. Coming to toxoplasmosis, it's a common zoonotic disease worldwide, but the diagnosis is underrated. Usually it is clinical. Serological evidence may help to confirm the diagnosis. ELISA-based IgG may add a value to the clinical, but negative result does not rule out toxoplasmosis. Then HIV, the diagnosis of HIV is first crucial step in the treatment and prevention. To diagnose the disease early, proper serological test is required. Again, nearly after 10 days, this RNA quantitatively increases in the plasma. Next, P24 antigen is expressed and it quantitatively increases to the level that are microbiologically detected. But these are transient. After 2 weeks of RNA development, IgM antibodies develop, followed by IgG. So basing upon this, lab investigations are available like HIV, ELISA, P24, Western blot, qualitative and quantitative PCR. ELISA developed as a screening test. It has 5 generations actually. The first generation to detect IgG against the HIV. Recent generations, they detect both IgG and IgM as well as P24 antigen. Third and fourth generation, they reduce the detection period to 20 to 25 days. The fifth generation reduced it further to 1 week, while the third generation is used as a screening tool, and the fourth generation is used for blood banks. P24 antigen immunoassay, this detect the disrupted P24 antigen from the serum. However, they may not be detectable in all the patients who are already positive with HIV antigens. The Western blot, this is an immunosorbent blot technique and has been used to detect antibody. The patient serum reacts with the strip after the gel electrophoresis, and according to the type of antibody present, the serum will bind to the antigen and produce a characteristic color band. Presence of one core band and one envelope band is required to declare it as a positive result. True HIV needs confirmation, can be confirmed with PCR. So rapid diagnostic tests are fast, and they use both immunochromatographic and immunofiltration techniques. They can detect HIV 1, 2 as well as P24 antigen, and it takes less than 30 minutes. After the diagnosis of HIV, we need to constantly rule out any possibility of secondary infections. Other immunological tests like PCR are used for that, and it has quite a high sensitivity in cases of viral as well as toxoplasma infections. So now we will move from infection to the immunological non-infectious conditions, and for them we have these anti-nuclear antibodies. These antibodies are a specific group of antibodies that recognize nuclear and cytoplasmic cell structures. They are tested by immunofluorescence, which is the standard method and used as a first step screening test for autoimmune diseases. Other lab tests includes ELISA and enzyme immunoassays. So different patterns are seen that are broadly classified into nuclear, cytoplasmic, and mitotic groups. Another test parameter we see is the ANA titer, which is directly proportional to the antibody concentration and is expressed with a quantitative scale of values. Although this ANA test has a high sensitivity of around 100% for the diagnosis of systemic lupus, it is not specific for this diagnosis, and it may be positive for other systemic rheumatic diseases and organ-specific autoimmune diseases, viral infections, and as well as in healthy individuals. Therefore, in a case of positive ANA, additional testing for anti-double-stranded DNA or anti-dsDNA is recommended, and other antibodies like anti-Rho, anti-La, this test could also be done. Then coming to the rheumatoid factor, another point I would highlight in SLE patients is that retinal vasculitis, they correlate with the systemic diseases. So if you have a patient with retinal vasculitis, SLE patient need to have a adequate control of the inflammatory process. Coming to the rheumatoid factor, these are class of immunoglobulins that have different isotypes, and this nephrometry and ELISA are the methods to detect the rheumatoid factor. Other methods are like immunoassays and classic Rose-Waller tests. These are hemagglutination tests for rheumatoid factor in serum. They depend on the ability of the rheumatoid factor to agglutinate ship erythrocytes that are coated with anti-ship immunoglobulins. So these latex particles aggregate in the presence of IgM rheumatoid factor. Rheumatoid factor in RA may be used in monitoring the disease as it parallels the decrease in clinical activity of patients under treatment. High titers are associated with an aggressive form of the disease. Therefore, this factor should be included in the workup of patients, especially with episcleritis, scleritis, peripheral ulcerative keratitis, anterior uveitis. The testing is why it is important, because in JIA patients, if the JIA is RA positive, then the risk of anterior uveitis is more than in any other subtypes of JIA. Although it is not very effective in diagnosis, but this prognosticating part is very essential. So sometimes it is very cheapest and used as a screening test, but if it is not detected, which is very common early in the course, and it is also not specific, then if with a clinical high suspicion of rheumatoid arthritis, you can go ahead with anticyclic citrullinate peptide, that is anti-CCP antibody testing. So citrulline is an atypical anti-amino acid which are present in inflamed synovium, And based on American college, the specificity has been found to be around 73.5 to 100%. Also, if anti-CCP and RA factor are positive, it has a more and worse ocular involvement. Coming to the next antibody, anti-neutrophilic cytoplasmic antibody, or the ANCA, that reacts against the proteins located in the granules of neutrophil cytoplasm, and they produce three different characteristic appearance. Two of these are commonly used, that is cytoplasmic, where they stain the cytoplasm, and perinuclear, where they stain the perinuclear part. Another severe one is that it has an excess of antibody, so it creates a diffuse pattern. This cytoplasmic appearance is found in granulomatosis polyangiitis patients and perinuclear in microscopic polyarthritis. So early diagnosis of this is very important. Another point I want to highlight here is the cross-reactivity between ANCA positivity and tuberculosis. So this tuberculosis, they stimulate the release of oxygen from the activated neutrophils. This interact with the phenol glycolipids of the cell wall and release lysosomal enzymes. So these lysosomal enzymes could have autoantibodies against the granular components, and that can be misleading. So a careful interpretation is needed, especially in TB endemic conditions. Coming to HLA typing, it is a protein that is present on the surface of the cells that constitutes the major histocompatibility complex. These are located in the short arm of chromosome 6 and has conventionally based on serological methods. We have different HLA association in various diseases as highlighted here. Another theory purpose question is polymerase chain reaction. So we will discuss this in brief now. It has been invented by Carey Mullis in 1983. This is an important tool for diagnostic confirmation in intraocular inflammation. Especially, the process usually involves pathogen-directed nucleic acid amplification. So the process begins with denaturation. Samples of interest are heated to 90 to 95% to denature the double-stranded DNA, and that produces a single-strand DNA. Then annealing occurs with the primer. The primer is usually two short oligonucleotide primers, around 15 to 20 nucleotides. They bind to its associated complementary sequences with single-stranded DNA. And this process is repeated, and the DNA synthesis is done with the help of DNA polymerase to synthesize the targeted sequence from the annealed primers that have been produced earlier. So the time usually takes around 2 to 5 hours. Tear fluid also can be used for diagnosis. Aqueous aspirate, we need around 50 microliter. Vitreous aspirate, around 100 to 300 are sufficient. They are aseptically transferred to a new sterile plastic vial and frozen at -20 to -80 if DNA is not extracted immediately. The sample should remain frozen until processed, and freeze-thaw cycles will release nucleases that will degrade all the RNA and DNA. So its advantage is that very small amount is sufficient and sensitivity is very high. However, high sensitivity comes with high false positive rate. High specificity comes with high false negative rate. And also it cannot detect the organism for which primers have not been provided. Various other types of PCRs are available, that is nested PCR, multiplex PCR. Nested PCR I just discussed. Multiplex PCR, it is it has an added value when you have a negative result. The sample are very less and it can help detect multiple organisms. Others are reverse transcriptase for RNA viruses, and a few others are real-time PCR. So this real-time PCR are very useful. Why? Because this nested PCR can detect even the dead organisms. So real-time helps in detecting actual growing organisms in these conditions. Coming to PCR analysis in intraocular fluid, it has different sensitivity and specificity for different conditions with different positive and negative predictive values. Coming to recent advances, metagenomics, it refers to the study of genetic material recovered from various body fluids and tissues. Tremendous advances in sequencing technologies have been made over the last few years. This MDS, that is metagenomic deep sequencing, is a rapid and highly sensitive diagnostic tool. It can detect organism with single assay, and around 20 microliter is sufficient, but again contamination is a major issue here. Next gen sequencing has been gradually evaluated for both infectious as well as to find any HLA correlation, especially in pediatric uveitis. Coming to certain other conditions, like if you suspect any Behçet's disease, you can do a pathology test. You can do a HLA typing of B5. Usually this is a clinical diagnosis again. Lymphoma, if suspected primary intraocular lymphoma, you can have a biopsy, cytokine analysis, MYD88 genome, or a radiological imaging, CNS imaging spatially. Rheumatological suspect patients, you can additionally have a sacroiliac X-ray joint X-ray done. Inflammatory bowel disease suspects should undergo radiology or biopsy, endoscopy, even HLA typing. Sometimes they are HLA-27 positive or HLA-7 positive, that prognosticates the disease. TINU, if tuberculointerstitial nephritis and uveitis syndrome. Renal biomarkers like beta-2 microglobulins are very useful, and even renal biopsy can be done to do the diagnosis. Multiple sclerosis, MRI, lumbar puncture that shows an oligoclonal bands are sufficient. If you suspect an autoimmune retinopathy, then anti-retinal antibodies, systemic imaging to rule out any malignancy, and even PET scan are also useful. For exam point of view, we'll discuss a little bit of pathology test. It is used in the diagnosis of Behçet's disease. Again, the volar aspect, intradermal injection of 0.1 ml isotonic salt solution is used with 20 G needle, 3 to 5 ml intradermally at an angle of 45 degrees, and the results are read after 24 to 48 hours. If there is an erythematous papule or pustule of more than 2 mm size, then the test is taken as positive. Not only for diagnosis, routine blood tests are also to be done. Like CBC, complete blood count, erythrocytes sedimentation rate. Often they do not yield specific diagnosis, but they could sometimes provide clue to the underlying clinical conditions. As for example, eosinophilia in a patient can point towards sarcoidosis or parasitic infections. Similarly, if we have a raised blood cell count, that can indicate bacterial infection. If lymphocytosis, viral infection could be suspected, or tuberculosis even. So knowledge about blood count is very important if we are planning for immunosuppressive treatment. Similarly, peripheral blood smears, it's very cheap and could help to rule out any malignancies. Liver function test, renal function test, these blood glucose levels are need to be done to establish a normal baseline levels and to monitor the response, especially when the patients are on steroid and immunosuppressives. Other labs are in research purposes like histopathology, immunohistochemistry, and molecular biology in cases of an enucleated or eviscerated specimen. In that case, the other eye could be saved if we have a tissue diagnosis at hand. Proteomics, again, are very emerging, and microbiome studies are also evaluated in immune-mediated uveitis. So I guess we have heard so much of these words that we are confused to ask what are these and how are these relevant in uveitis practice. Although the foundation of uveitis diagnosis remains the patient's history and thorough examination, these are insufficient to make a definitive diagnosis. Currently, few guidelines are there that address the appropriate lab evaluation for any uveitis patient. False positive can lead to unnecessary testing and expose the patient to additional risk and morbidity. However, if we omit an appropriate lab test, that may result in a mixed diagnosis. Indiscriminately, if we keep on ordering all the tests, that can lead to excess healthcare cost and confusing results. So here comes the confusion part. As we all discussed in the previous class, that uveitis is very confusing. I guess the confusion starts at this level. Clinical features and imaging are straight away, as has been very anomalously discussed last class. So we need to be very careful when this labs comes into play. We all have heard about something called phishing a uveitis patient. Many come with tests already being done elsewhere outside. Sometimes we fish in the wrong direction. So we should learn the art of phishing and get hold of the correct one. So let's begin solving each entity. Sensitivity and specificity are expressed as probabilities. Sensitivity is the probability of a lab test being positive if the patient has the disease in question. Specificity is the probability of the test being negative if the patient does not have the disease in question. So like I have mentioned earlier, anti-nuclear antibodies, these tests have a particular sensitivity and specificity for lupus, but it has a different sensitivity if we suspect a juvenile idiopathic arthritis. This sensitivity and specificity, these are technically only accurate for population in which these parameters are established. And I would like to highlight that all these lab tests are validated on non-ophthalmic literature and very rarely validated on the uveitis patients. So in clinical use, positive predictive value and sensitivity sometimes are confused. That leads to a misinterpretation of the lab test. Direct application of sensitivity and specificity to the clinical decision is generally not very useful. As for example, if we see a patient of anterior non-granulomatous uveitis and we do a TPHA test, the TPHA comes positive. As discussed earlier, TPHA has a sensitivity and specificity of around 99%. So it does not mean that the patient has 99% chances of syphilis. We have to take the prevalence into account and identify the positive predictive value. So the prevalence in such cases is only 1 in 10,000. So the chance is around 1%. So predictive value, this depends upon the prevalence. The prevalence is the proportion of a population with the disease in question at that point of time. To decode this, we have this Bayesian analysis and Bayes theorem. This is actually a formula for calculating conditional probabilities and must be understood and applied to establish a logical basis. To simply state, if a clinician knows the sensitivity and specificity of the test we discussed throughout the talk, the pre-test likelihood of the disease in question, then this theorem will provide the post-test probability of the disease. The positive test leads to calculation of a positive predictive value. Negative test leads to calculation of negative predictive value. This pre-test probability also depends on clinical presentation, anatomic pattern of the disease, as well as patient's ethnicity, geographical origin, and other demographics. So we saw that no lab test is perfect. All the tests are subjected to false positivity and false negative reaction results. So what is an ideal lab test? The test would have maximum utility for making or excluding a diagnosis when the tests are highly sensitive and specific, when the pre-test probability is intermediate, like it is neither very high or nor very low, when the test is played to its strength, that there comes the role of the clinician. So if the clinician is very certain that the disease is present, the pre-test value goes up to 100%. So there is likelihood that it might reject the negative test. So there is some concept like rule out testing that has better usability in cases of inflammatory conditions. Let's understand this concept of likelihood ratio, the uncertainty of a test, which is just the opposite of positive predictive value and negative predictive value. So from this graph, as we can see, pretest, if the pretest value is very low and the test comes positive, then there is a chance of a false discovery. Conversely, if the pretest value is very high and the test comes negative, then the omission rate is very high. So let's put this theoretical analysis into our clinical practice. Actually, investigations all starts the moment patient walks in the room. So this patient had a fibrinous reaction and hypopion sitting over there. We have, and the patient also gave a history of back pain, and we ordered HLA-B27 in this patient. Also, we did fishing in the wrong direction, ordering all these investigations. Now the patient came with HLA-B27 negative and all these other tests being positive. At this stage, we need to take into consideration the sensitivity, specificity, and the pre-test probability, which depends upon the local epidemiological study. So during the second class, I guess, it has been said that HLA-B27 has a prevalence that spans over 20% to 88%, and there it comes into play. In Indian population, many, around 40% are positive, whereas others are negative for HLA-B27. So here, even though pre-test probability is very high, test came negative, so there is a chance of omission, and then confusion starts. So we should not be biased by the lab test. We should have a proper idea of each test sensitivity, specificity, probability, pre-test, and the prevalence. Another case scenario like this where we suspect viral. So if we just go ahead with the lab test of PCR, if it comes positive, then it gives a 100% diagnosis to the clinical suspicion. So lab and systemic imaging do have a pivotal role if they are played smartly and had a careful interpretation. At this outset, I would like to thank all my mentors and Santosh Honavar sir for giving me this opportunity. Thank you.
Thank you so much, Dr. Gazal ma'am, for that wonderful talk. I know it's a very, very long topic, but you somehow tried to squeeze in within 50 minutes so that we have time left for questions also. So thank you so much for that. Abhilasha ma'am, Parthopratim sir, I think we can take the questions now.
Yeah, laboratory diagnosis of uveitis, if you see, often asked as a broad question in various postgraduate examination. And it's a very, very, very vast topic. And Dr. Gazal did an excellent job summarizing it so lucidly for the postgraduates. I think many people will watch it again, the recording, which is available in Facebook and YouTube, and while preparing this topic. So there are a lot of questions here today. And we have two experts with us, Dr. Kalpana Babu, the president of Uvea Society of India, who has done phenomenal work on ocular sarcoidosis, and we have Dr. Mamta with us. So first, let's go to Dr. Kalpana ma'am. There is a question by Dr. Gautam, who has asked, clinically, if TB uveitis is suspected, do we directly go for quantiferent gold or TB PCR without even considering the tuberculin skin test?
So before I answer that, I would just like to congratulate Dr. Gazal. It's such a difficult topic, and you've so elaborately covered the whole thing, including the base and the predictive values and all that. So this is where I think it's very important to answer your question also, Partho, because whatever we are looking at are indirect evidences. So generally, at least in the clinical practice, what we do is, we do a combination of both MAN2 as well as quantiferon. And as we had learned from the previous seminars, the pattern of uveitis is so very important. So if you are very sure that you're thinking about TB uveitis, then I would look at these two together along with the chest CT. That will be my armamentarium thing, rather than just one test. Trying to say it is TB related, at least in our part of the world, which is highly endemic for tuberculosis.
Yeah, that's, I think, very valid point. So another question on similar, I think it will be a very favorite topic of you. While differentiating between sarcoidosis and tuberculosis, what are the points to take care while interpreting various laboratory tests?
So as you rightly said, both the diseases are very similar clinically, radiologically, and histopathologically. So the problem when we are interpreting these, when we are looking at a patient, whether it is TB or sarcoid, as Gazal had shown so very well, that you can have TB MANTO negativity in miliary tuberculosis as well. So just plain negative MANTO and negative quantiferon will not rule out tuberculosis, especially in these conditions. So I think infection is something which we always have to keep in mind. Though there are, I mean, in further courses, we'll be looking at each diseases. So we'll come up to that. But I think when we're looking at sarcoid, probably we'll have to look at multiple things which we need to take home. One is a clinical pattern. The other one is the lab tests, which you're saying, which are like a negative MANTO, negative quantiferon, all with a pinch of salt, and the HRCT as well. Now, and of course, a biopsy, wherever there is, as you rightly pointed out, if you can get a biopsy and then put it for culture or PCR, that is very, very important. So in any part of uveitis, I think biopsy is, I think, very, very crucial in all these. But in case if you don't have a biopsy, I think we have to rely on indirect evidences like these. And in addition, I think probably the other things which I will look for in a sarcoid will be probably a bit of lymphopenia in these patients. Some patients have increased serum calcium levels as well. So I think we will look at it as a whole rather than one test at a time.
Thank you. Thank you. Dr. Mamta, you want to add anything? Differentiating between sarcoid and tuberculosis?
I think what Kalpana said, I don't think we can add. It's basically a combination of all the clinical as well as investigations and other imaging. So one thing helping in the other thing and then complementing each other. So what Kalpana said is rightly said, we have to combine all the things and then we make a diagnosis and reach it. And it's important to differentiate TB and sarcoidosis because we should not overtreat patients with ATT, which we commonly see that it's an easy way to go. And a lot of patients are on anti-tubercular therapy, which they just stop in between. Then it's like creating more of drug resistance. So diagnosis of the disease, because the pattern can be very similar. Granulomatous uveitis, what we have learned. And what Gazal has pointed very nicely, that it's very important to differentiate the two, even if the phenotype is more or less quite similar. It's the disease does not present in an ideal way all the patient. That's what I would suggest postgraduates, that you should know the phenotype and then go stepwise approach in differentiating these and make a differential whenever you diagnose your disease.
So we have another question from Dr. Shruti, who has asked, in India, if a patient has been diagnosed to have HIV-associated CMV retinitis, do we investigate always for a coexisting TB? If no, which subset of cases should be considered for the same? So I'll just ask this question, repeat the question. In India, if a patient has been diagnosed to have HIV-associated CMV retinitis, do we investigate always for a coexisting TB? If no, which subset of cases should be considered for the same? So I'll just go to Dr. Mamta. Can you tell?
So very good question, Shruti. I really admire that you really thought of these co-infections in HIV patient, which is very common. Why? Because it's an immunosuppressed state of the patient, and they are prone to infections like tuberculosis, especially in the endemic country, and CMV retinitis. Then it can also be toxoplasmosis. It can also be syphilis. But I would not say that you have to really investigate for tuberculosis if the clinical thing you see is only CMV retinitis. CMV retinitis in an HIV patient, we know it's a very common manifestation, but given it a choice that we need to rule out other systemic involvement, even if it is not an ocular TB lesion, which we are seeing, I think it's very important for us to send the patient for a complete systemic test for the patient. We are treating only CMV retinitis, but ruling out other infections, be not ocular, is also very important. So we don't need to investigate for TB if we are not seeing a clinical ocular TB in an HIV patient with CMV retinitis. But then we have to send it to an HIV specialist too. I hope this answers your question.
Anything to add, Dr. Kalpana?
I think here, probably I would just like to highlight what Gazal showed at the last, what are the routine tests which we normally do including the complete hemogram and all in all patients with uveitis. I think this part I would like to overemphasize, and that has to be done as a routine in all patients with uveitis. And I think one of the other factors which comes in this is chest X-ray as well. So in that aspect, probably, I mean, as what Mamta rightly said, maybe because it's a systemic disease, they'll have multiple organ involvement. A HIV specialist or an infectious disease specialist will be the right person to do. But in a case which is not HIV and you'll end up with something else, other types of uveitis, I think chest X-ray is mandatory, especially if you're looking at, starting these patients on steroids at some point of time.
Very nice. So I just want to take the opportunity to ask you, because the topic is so relevant. So how important is the serological test when we are dealing a case or suspecting a case of viral uveitis, like viral anterior uveitis? No, we see many people are relying on the torch titer and treating the patient on the basis of elevated level of herpes simplex. So how important is the serological titer of this herpes viruses while treating a case of viral uveitis?
I think it's a very, the problem is, I think this is routinely done, but this should not be done, because I think we shouldn't look at torch profiles or the titers of these virals systemically. And what we need to look at it is from the eye, and that is by the PCR. So I would just like to highlight that serological tests for viral antibodies usually do not play a significant role in the diagnosis of ocular inflammations.
Dr. Mamta, because you have a lot of interest in CMV. So if you are suspecting CMV anterior uveitis, do you order serological test?
See, I think one thing what we could look at is probably you can look at the load in the body. Actually, for the HIV, at least you can look at the load, the mRNA load of the CMV or HIV. Probably you can look at that, especially in transplant patients. I think that's where it counts. And here you look at the type, because many of these patients present with CMV retinitis initially in one eye and over a period of time present in the other eye, and it becomes a little refractory. So these are patients, I think it's better to look at this, the load in the blood, and then treat them with oral antivirals for that long. I think this is the only place I think it will really help, but not for a diagnosis as such.
Thank you, ma'am. Any other question? I think there is a question by Dr. Aniruddha. Please elaborate how to go about testing for tuberculosis in an endemic country like India, which tests to choose and how accurate are they? Over to Dr. Mamta. Ma'am, please tell us.
I think it's the same thing. So it's a difficult question to answer that, which is the exact test for tubercular uveitis or in an endemic country. But what we normally do, a chest X-ray and a MANTU. If you can do a quantiferon TB gold test, can also be done. And then it's, of course, a complete blood count. For tuberculosis, these are the things, and we have to take it, what you call one complementing the other. If we have a strong suspicion, then we can directly go for HRCT, because there's enough literature now that HRCT is much more sensitive than a chest X-ray. Most of the time, we all know that chest X-ray is normal, but we pick up more findings for tuberculosis, sarcoidosis on HRCT. So a MANTU test is must. CT chest we can do, and quantiferon plus minus, because it's an expensive test if patients can afford. And then, of course, a complete blood workup and the clinical manifestation. So all these combined, they can. It's very important. I always say that for TB, it's very important to know what is the phenotype for all the different uveitis: anterior, intermediate, posterior, and pan-uveitis. So you should see what can present as TB. And we know that for the same bug, it can present as different manifestations. So be very clear about the clinical things and the criteria, diagnostic criteria, and then investigate accordingly.
Thank you.
Can't hear.
Can you unmute?
Yes. Abhilasha, ma'am, you're on mute.
Yeah, there's one more question. Can you elaborate the interpretation of serum electrophoresis in diseases like amyloidosis? If globulins are raised, what are the other systemic tests required in the patient? Amyloidosis, serum electrophoresis.
So I think, see, if I can answer that. So
yes, ma'am.
So basically serum amyloid, amyloidosis, the definitive diagnosis is a biopsy. So I really wouldn't know whether any other test would really be very helpful to that. But what you can say is when you have increased, basically we look at the globulins in two conditions. When we are planning to start them on biologics, then we look at the immunoglobulin G levels actually. In certain conditions, these are altered. Like, for example, in liver diseases or renal diseases, these are usually on the lower side. Whereas in inflammatory diseases, these can be on the higher side. So I don't know, main thing from my side, I think when you're looking at electrophoresis is when you're looking at immunodeficiency conditions or you're looking at malignancies, like multiple myelomas or something to that effect. So these are the only conditions where I really look at electrophoresis. And probably if I'm going to start these patients on rituximab, then these are cases where we look at the immunoglobulin G. Basically, you're trying to look at the body's ability to fight infections. That's the only thing. I mean, probably if anybody else can answer, maybe JB is here regarding amyloid and I think.
Sir,
I think that's immunoglobulin level doesn't really make much difference. Is the biopsy is the final say. You cannot make a treatment based on the immunoglobulin assay and amyloidosis.
Thank you.
If the biopsy has come out to be positive and also we have raised serum immunoglobulin levels, what are the other tests we should be ordering for the patient, sir? Like any screening that we should be doing for the patient?
Not really.
They would do a bone marrow biopsy if I'm not wrong.
What about 2D echo, sir?
I'm not sure.
Okay.
Right.
Ma'am, I have one more question. If we have a patient who we have diagnosed as nodular scleritis, what are the battery of tests that we should be ordering? Like if it's the first visit of the patient to our OPD and we have diagnosed her as nodular scleritis.
So nodular scleritis, I would say it depends on other factors also. What is the age? It's the first time. We can always treat it and not investigate, but most of the time patients do say it's a recurrent. So I would actually in my first time nodular scleritis, young patient comes, I can just treat with oral NSAIDs or topical steroids and wait and watch and follow up. If it recurs, which we see commonly, then we order the tests, which include again a CBC complete and then RA, rheumatoid factor, ANA, and if we see that patients don't mind, we can also order ANCA test to just know all the collagen and connective tissue diseases, and also the CRP, C-reactive protein. And sometimes it's important to also rule out infections. I would also order because we want to start them on steroids. I would also start investigate for RPR, TPHA, and TB workup, like MAN2 and chest X-ray. So that will be my workup for to rule out both infection and non-infection. Depending again on the history and the clinical acumen. But first time, I think I can just treat with oral NSAIDs and topical steroids.
I think it's, I agree with Mamta. I think there's another thing which we need to keep in mind is look at the ocular surface as well. Many times the lid is unhealthy and, that itself, there is a trigger and there is an inflammation localized as well. So if it's, I think we'll have to look at both the local as well as systemic aspects. In such patients with nodular episcleritis or nodular scleritis. And maybe another important test which you can also do is serum uric acid, which is generally missed. And that is something which you can have in some patients, this kind of a presentation. So maybe you could look at uric acid levels also in a little, middle-aged or older patients actually. But I think an important test is your ESR and your C-reactive protein, which would give you an idea on the systemic inflammation if it's present or not. Along with that, probably you need to look at what Mamta said, all these conditions, ANA, ANCA and all that. And I think a urine examination. So presence of CAS or anything in the urine like that will definitely show that there is something going else in the kidney. And you need to rule out, basically you're trying to look at if there is a systemic disease which is very aggressive and that has to be treated. So the only thing which comes to my mind at that point of time is to rule out ANCA-related vasculitis or a collagen vascular disease, which both of them have a tendency to affect the kidney. So it is important to look, even a routine urine examination would give you a lot of clue. If you see a lot of CAS or albumin in the urine, it's important to take this very seriously.
Sure, ma'am. Thank you.
And thank you so much, everyone. And I must tell you this, that I've just received information that this lecture today, considering the fact that it is a very important topic and Dr. Gazal has covered it so well, and the discussions have been so healthy, we have a very strong viewership today. And I mean, the postgraduates already know that this is a very important topic for all. So thank you, Dr. Gazal, for covering such an important topic in such a beautiful and, streamlined manner that it has gone sequentially. Thanks so much. Thank you so much for that.
Thanks, Rodika. It's a pleasure. It's always learning.
And you've answered all our questions as well, because we need this in OPD nearly every day. So oculoplasty and oncology also requires you all every day. So definitely. Would you like to say something before we close the session?
I mean, I've learned a lot from Gazal's lecture, actually starting from each disease to even going up to Bayes' theorem and the positive predictive values and all that, because these are questions which can be asked in Viva as well. So actually, I'm very impressed that the whole thing has been covered so excellently by Dr. Gazal. Congratulations to you and the entire team.
Thank you so much, ma'am.
Yeah, that was a wonderful, what I don't read, Gazal made me read the whole thing.
Thank you so much, ma'am.
Yeah, so it's interesting to see all these things, and it's very important to keep revising these things. So it's a revision for us also.
Right. Shefali?
So I have two, just a second. I have two announcements. Next, we meet on December 21st, which is the topic ancillary investigations in uveitis. That is part 1 by Dr. Padmamalini. So see you all coming Wednesday. And the next announcement is regarding iFocus Physical, which is going to be held in New Delhi from February 26th to March 5th. Registration is open, and we hope that you all register in huge amount, so that you have you're really prepared for your exams for the coming year. The registration can be done on the link that is provided here. So go ahead.
And just something to add, the last iFocus session was physically held in 2020. And I was there as a postgraduate, and I'm telling you that the very fact that I was present there, I could remember and take home certain things which were eventually asked in the exam. So, it's like the whole course is summarized in a week. So it's not something to, advertise for any of us. We're actually encouraging you to join, because we are already anyways at the verge of closing the registrations, because the registrations are filling up. So go ahead and fill up your register online. It's for your benefit. And even on the first and the last day, that is 26th February and 5th March, the hands-on courses will be held. So this is something that you kind of take lifelong, not just for the post-graduation. So I'm hoping to see all of you there. So
Thank you so much,
everyone.
Thank you.
Good night.
Thank you. Good night.
So much.
Thank you.